Well, good afternoon, all. We're going to go ahead and continue on with our lecture series discussing autonomic dysfunction after spinal cord injury. Basically, what we're hoping to do is to review the anatomy and physiology of the autonomic nervous system, particularly as it integrates into the central nervous system. We'll talk about the implications of spinal cord injury and the pathology associated with that. And then obviously a big part of this is to discuss autonomic dysreflexia. So we will review diagnostic management and treatment options for autonomic dysreflexia, and then discuss opportunities for cardiovascular research. So again, I want to start off with a case vignette. This is a 45-year-old gentleman with C6, Asia Impairment Scale A, tetraplegia. You are contacted actually for his hypertensive crisis. His past medical history is notable for an upper motor neuron bladder with the Trussor sphincter dyssynergia. He has had sphincterotomies twice, once in '98 and again in 2008, and has had a suprapubic catheter since 2005. One of the consequences of that is recurrent stones, nephrolithiasis, and he is now status post-ureteral stent placement, awaiting lithotripsy. So his usual blood pressure is 98/57 as a result of neurogenic hypotension. He has been on Florinef and Midodrine previously, and he's got a 12-lead EKG that is consistent with left ventricular hypertrophy, which is a little puzzling because of his low blood pressure. His current medications include oxybutynin for his bladder, baclofen for his spasticity, Valium also for spasticity, and Florinef. He had recently been stopped from the Midodrine, and then he has nitropaced on an as-needed basis, and previously had been on dibenzoline, but that has been discontinued also. So now you're contacted for a hypertensive crisis with a blood pressure of 170/120 and a heart rate of 52. And so I ask you, although I'm going to be generous today, what would you do? And you don't have to tell me yet. How nice is that? Dr. Gator, you're getting too soft in your old age. So let's talk through a little bit of the central nervous system and integration with the autonomic nervous system. So the somatic nervous system, obviously we've discussed and have recently gone through the ANS-CNS classification system for neurological level and completeness of spinal cord injury. What I didn't spend much time on at that point was the autonomic nervous system, and recognizing that the sympathetic nervous system arises from the thoracolumbar regions of the cord. That is going to have significant implications if you have a spinal cord injury at the thoracic level or above. So we'll talk through that in a little bit more detail. The autonomic nervous system, as you know, is comprised of the parasympathetic nervous system, and that's the craniosacral axis, so the cranial nerves, and the sacral nerves, 3, 4, and 5 in particular, and then the sympathetic nervous system, which basically is comprised of thoracolumbar areas of the spinal cord. You remember that T2 through T4 includes the cardiac plexus, and then particularly as we get down towards the issues of GI and GU, T5 through T11 is the celiac ganglion as we go through there. So how does the autonomic nervous system communicate with the central nervous system? Remember back in anatomy, and you were told about the sympathetic chain ganglion on each side of the cord or each side of the vertebrae as you were looking through there. And so this communication basically speaks as you have afferent influences, cell body in these dorsal root ganglion that come in and they interact with the preganglionic sympathetic cell bodies that arise in the intermediolateral horns of the spinal cord. And again, this is in the thoracic and the lumbar regions of the cord. So basically, you have afferent impulses coming in, efferent impulses going out. These preganglionic sympathetic fibers are going to synapse with postganglionic fibers or postganglionic organs and subsequently have their influences. So they speak to each other, if you will, through the transmission of neurotransmitters. Acetylcholine, you all are very familiar with, released from all, let me say that one more time, all preganglionic fibers within the autonomic nervous system. That's parasympathetic as well as sympathetic. Preganglionic fibers communicate via acetylcholine. And so acetylcholine, you recall, will influence nicotinic receptors, and those lie particularly in the autonomic ganglion, adrenal medulla, and the skeletal muscle motor end plates, as well as muscarinic cholinergic receptors, for example, cardiac muscle, smooth muscle, bladder, and other glands. So acetylcholine is also the postganglionic neurotransmitter for the parasympathetic nervous system. And then we have norepinephrine and epinephrine. So these are neurotransmitters of the postganglionic sympathetic fibers. And what is the difference between norepinephrine and epinephrine? I'll just remind you that at the end of this amine group, norepinephrine has no R group, no R epinephrine. And that's why it's actually named norepinephrine. And so it will influence alpha-1 receptors, alpha-2 receptors, and beta-1 adrenergic receptors stimulating the heart. So the difference between no R epinephrine and epinephrine is epinephrine has an R group. And so that being the case, it can also interact with alpha-1 and alpha-2 receptors, but it will also interact with beta-2 receptors, which is different from no R epinephrine. So anyway, within the autonomic nervous system, the sympathetic nervous system, again, is there to help us convey fight or flight. So this is going to help us to flee or to fight in response to a crisis situation. And so again, just looking at this a little bit more closely, you have afferent input coming through the basically dorsal root ganglion where you have your cell bodies. This input can be all types of noxious stimuli. Pain, temperature, and temperature that is too great. It can be related to anything that you or I would perceive as a noxious stimuli. A painful stimuli is basically conveying sensory information to the dorsal root ganglion, and then its synapses. This is the home of the cell body for the preganglionic sympathetic fibers. And then they will synapse either in the chain ganglion here or other ganglions such as the celiac ganglion, superior mesenteric ganglion, with postganglionic sympathetic fibers. And it's those postganglionic fibers that convey the adrenergic neurotransmitters, either epinephrine or norepinephrine. So the parasympathetic nervous system, as we talked about before, arises from the craniosacral axis. And its neurotransmitter, both preganglionic and postganglionic, is acetylcholine. So whereas the sympathetic nervous system conveyed fight or flight responses in a crisis situation, the parasympathetic nervous system is about energy conservation and paying back whatever was used during the crisis situation by the sympathetic nervous system. And so instead of seeing increased heart rate, blood pressure that we saw with the sympathetic response, under parasympathetic influence, you have a reduction in heart rate, stroke volume, and vascular tone. You have relative bronchial constriction, increased peristalsis and digestion, sphincter relaxation, bowel and bladder evacuation, and penile erection. So some of the consequences, and we'll go into these in separate lectures. You have cardiac consequences. You have pulmonary consequences. So for example, in a parasympathetic dominant nervous system, one in which you've had damage to the spinal cord that now prevents sympathetic outflow, you're going to have a parasympathetic dominance that is going to cause bronchial constriction and a lot of mucus secretion. So tight pipes with a lot of gunk in them, basically. And this is one of the outcomes that we'll spend a fair amount. Those of you PGY3s and 4s certainly know that our folks with higher levels of spinal cord injury need special respiratory management. And that includes duonebs to moisten secretions and open the airways, postural percussion and drainage or vibration, and then mechanical and exsufflation to clear those secretions all within 30 minutes of each other. And this is again because of a parasympathetic dominance. The sympathetic nervous system is essentially taken captive, and it can't respond as it normally would under these circumstances. So when we talk about influences on the cardiovascular system, again, we're going to be blocking sympathetic outflow. So what does sympathetic outflow do to the SA node of the heart, for example? The sinoatrial node. Sympathetic influence will increase the leakiness, if you will, of the SA node and therefore increase the heart rate. However, if it's blocked, such as in high thoracic and all of cervical spinal cord injuries, then you're not going to have that influence on the SA node, and instead you're going to have unopposed vagal influence on the SA node. So you're going to see a relative bradycardia, and that can drop all the way down into the 20s and into the teens as we go through there. So some of the responses that we see, and we'll go into this in more detail as we talk about cardiovascular dysfunction, but circulatory hypokinesis occurs because you have a reduced vasoconstriction and a reduced venoconstriction. You also have an impaired venous pump. We'll talk about that because the muscles are no longer pushing blood upwards through the venous system, and your inferior vena cava is now swollen, venodilated with about 2 liters of blood as opposed to its usual capacity of about 500 cc's. And so all of these are going to lead to an impaired left ventricular end diastolic volume and therefore impaired contractility of the heart. And as we talked about before, the parasympathetic influence on the SA node is going to give us a blunted chronotropic response, so that we rarely see heart rates of over 120 in our folks with T3 injuries and above. We do see fairly frequently dysrhythmias, particularly heart block, that goes along with this unopposed parasympathetic stimulation to the SA node. So the muscle pump, remember that the veins have valves in them, and when the muscles contract, it forces the blood through the veins, and then as they relax, the valves come back and they stop and they hold the blood at that particular level. So if your muscle pumps aren't working, then again, you're going to have a diminished blood flow return back up to the heart. And so we have multiple reasons. Part of this is somatic disruption because of the impaired muscle pump, but also venodilation because of, again, sympathetic blunting and impaired ventilation. So we're going to talk about neurogenic restrictive lung disease, but if you can't take a full breath, you can't create the vacuum that also helps to pull the blood back to the heart. And so these are 3 mechanisms by which you have a relative venous stasis and what we call circulatory hypokinesis. On the arterial side, you have reduced your afterload because of a, again, blunted sympathetic response. So you don't see vasoconstriction the way that you normally would. And so oftentimes when you hear somebody has a blood pressure of 90/60, you either think, oh, they've lost a lot of blood or they're septic, but most people don't think of neurogenic hypotension. And that's the scenario that we see with our folks with spinal cord injury. A new spinal cord injury will, again, block sympathetic influences, and you have a relative vasodilation throughout the vascular tree, and blood pressure plummets because of that. And so as opposed to hypovolemic shock, where you have low blood pressure and a tachycardia that tries to compensate for that, with neurogenic shock, you have the low pressure, but you don't have the sympathetic influence, the compensatory sympathetic influence on the SA nodes. And so your heart rate is also low and going lower all the time. And so, especially in the initial stages, we have to be very, very careful and judiciously administer fluids because we don't want to put people into pulmonary hypertension as we go through this process. So as we bring folks onto the rehab floor, what we're really looking to do in the first week or two is to get them to sit up without passing out. What? To get them to sit up without passing out because of neurogenic hypotension. They don't have a blood pressure, particularly as they sit up, that will allow them to continue to perfuse their brain. And yes, they just have a syncopal episode. And so we will do a number of different things, including abdominal binders to compress the organs against the inferior vena cava and squeeze more of the blood up back to the heart. We'll provide elastic stockings, not TED hose, but compression garments to also help the venous system in the lower extremities compress and get as much blood back to the heart as possible. We'll start off with salt tablets, move on typically now to fluoroepinephrine midodrine as we try to overcome the neurogenic orthostatic hypotension associated with spinal cord injury. So now it's time to talk about autonomic dysreflexia. First reported back in the 1800s by Anthony Bowlby. He described it as a massive sympathetic outflow in response to a noxious stimuli below the level of spinal cord injury, incomplete spinal cord injuries above T6. So it was a pretty good definition. It was almost exactly correct, but it also applies, as you know, to incomplete spinal cord injury. And complications of autonomic dysreflexia include stroke, seizures, organ failure, and death, all of which are suboptimal. So why T6? Why is that so important? Remember that the greater splanchnic nerve comes off at T7 and T8, usually. And so if you don't have autonomic control of the splanchnic vascular bed, which is the largest vascular bed in the body, then you won't be able to control your blood pressure very, very well. And so individuals with injuries at T6 and above who can't control the splanchnic vascular bed are going to be at high risk for developing a hypertensive crisis in response to a noxious stimuli. Remember also that T7 and T8 give off the nerves to the adrenal medulla. The adrenal medulla remembers that adrenergic organ that dumps out catecholamines, epinephrine and norepinephrine. So these are the main reasons why T6 is kind of the delineation. However, not everybody reads the anatomical textbooks, and we have some folks whose greater splanchnic nerve and nerve to the adrenal medulla don't come off until T10. And so we may see folks with T8, T9 paraplegia who still have autonomic dysreflexia. And so don't be fooled just because, oh, they're not at T6, they're safe. That's not the case. Or they have an incomplete spinal cord injury, so they're not at risk. No, an incomplete spinal cord injury doesn't guarantee that the sympathetic nervous system fibers conveyed in the spinal cord are intact. And so keep those things in mind as we talk through this. Other names for autonomic dysreflexia: George, Harry, autonomic hyperreflexia, mass reflex, paroxysmal hypertension, sympathetic hyperreflexia. I love this one. Paroxysmal neurogenic hypertension. Wow. And then autonomic spasticity. If you want to do a literature search and you want to make sure you don't miss something, you should include all of these pseudonyms in your literature search when you're looking for autonomic dysreflexia in persons with spinal cord injury. So it varies somewhat in the literature. Somewhere between 50 and 85% who have an injury with T6 or above will experience autonomic dysreflexia. although there are case reports as low as T8, and I've seen cases at T9 and even T10 with true autonomic dysreflexia. Recognize that this can be either complete or incomplete spinal cord injuries. And the onset won't rear its ugly head until after they are out of spinal shock most of the time. So typically the first reflex you see as somebody emerges from spinal shock is the bulbocavernosus reflex. When that happens, that also tells you, oh, that sphincter reflex is happening, which also tells you probably the bladder reflex is happening. And when they both contract at the same time, generates high pressures that you and I would experience as a noxious stimuli, very painful. A person with spinal cord injury doesn't get that. They just put out this massive outflow, sympathetic outflow that causes splanchnic vasoconstriction, hypertensive crisis, stroke out and die. Suboptimal. Thank you for those of you who are remembering this. Usually, folks who will develop spinal cord injury will see it emerge between 6 and 12 months after the initial spinal cord injury. Linden reported out in 1980 that over 90% will have had their first episode of autonomic dysreflexia within 12 months. So theories about this. So part of this, recognize, has to do with the receptors. So I've told you that the sympathetic outflow is blunted. So whenever you have receptors that don't get activated, in other words, you don't have the catecholamines, in this case, adrenaline or noradrenaline, present, those receptors increase their sensitivity and they increase their numbers, wondering, you know, what are we missing? Where's that sympathetic influence? Where's the epinephrine and norepinephrine? And so in response to no stimulation for a period of time, they actually increase their sensitivity and their numbers. So that now even a little dab of sympathetic influence will sound like, it's like, I don't know if you guys have ever, you're watching a movie or something and the volume's really, really low on that, whatever that was. And then, so you turn up the volume all the way to 90 or 100 in order so that you can hear it. And then you put it on a regular TV station and it just blasts. That's what these receptors are experiencing when they finally have the catecholamines available to them. And they shock and they vasoconstrict in particular as we go through that. So what does this look like? A noxious stimuli below the level of the injury, most typically bladder distension, is going to send afferent impulses up the cord. But those influences are blocked at the level of the spinal cord injury, and you get this reflex sympathetic outflow that causes splanchnic vasoconstriction and hypertension. The increased pressure is sensed by baroreceptors that send information to the medulla, sends information back down to the heart to cause a relative bradycardia. But below the level of the injury, they remain vasoconstricted. Above the level of the injury, flushing, sweating, pounding headache that we know as autonomic dysreflexia. So the clinical presentation, this is important, is an increase of more than 20 torr, that is 20 millimeters of mercury above their baseline systolic or diastolic pressure. This is why I insist on you listing out what the baseline blood pressure is, so that if I'm on call, I know, you know, the person has a blood pressure of 110/80. Oh, that no big deal. Except for me, that may be a big deal if their baseline was 88/60. So anyway, this is typically associated with bradycardia, but we've also seen evidence in the last several years where initially you see a relative tachycardia, and until the pressure gets high enough, that tachycardia isn't offset by this reflex bradycardia that we talked about, typically associated with autonomic dysreflexia. The pounding headache associated with this is typically sudden onset, bilateral, in both the frontal and occipital regions. And it's felt to be due to a lack of sympathetic tone and, in fact, dilation of pain-sensitive cranial arteries rather than the blood pressure itself. So surprisingly, at least to me, this is not related to the level of hypertension, but it's more related to the pain-sensitive distension of these cranial arteries as they go through there. Other signs and symptoms of autonomic dysreflexia include the sweating and flushing above the level of the injury. There's a very, very clear demarcation on folks. You can see them sweating literally at the level of the spinal cord injury on their chest or their back, for example. Pallor below the level of injury where they're vasoconstricted. They may also have some nasal congestion above the level of the injury as they're trying to vasodilate and dissipate some of the high blood pressure they're experiencing. Piloerection, so the hair will stand up on the back of their neck. They may show Horner's syndrome. This is going to be actually rare unless the person has a Brown-Séquard injury, because typically it's bilateral in terms of the presentation. And then priapism, they're not just happy to see you. So the morbidity and mortality associated with autonomic dysreflexia and this hypertensive crisis includes retinal hemorrhages, intracerebral hemorrhages, subarachnoid hemorrhages, myocardial infarction, seizures, and death, all of which are suboptimal. Yes, just you got to help me out here, even though I can't hear you. Urological causes, the number one cause of autonomic dysreflexia is in fact number one, urine. So typically bladder distension, bladder calculi or renal calculi, not trig, not geometry, you knew that was coming, not algebra, it's calculi. So stones that actually cause irritation, urinary tract infections, bladder spasms, trauma, and cancer. And so all of these can cause autonomic dysreflexia. Recognize that somebody who has not experienced autonomic dysreflexia before and has the first time with a bladder distension of 1,000 cc's. Okay, now just imagine, if you will, your bladder, which typically is very, very painful at 500 cc's, now expanding to 1,000 cc's. Any of you ever torn a muscle, a hamstring, for example, or something like that in sports? Yeah, that was painful. Your bladder, when it distends that large, is also experiencing micro tears, and lots of them. And those don't heal themselves overnight. It takes several days. And so the person may continue to experience autonomic dysreflexia in response to an acute episode of bladder distension for days. So once you find the cause, typically, yes, their blood pressure will go down, you cath them, and you're patting yourself on the back, but then they may continue to have episodic autonomic dysreflexia until those micro tears have healed. So GI is the second cause, number two. Number two is the second cause of autonomic dysreflexia. So a distended bowel, an ileus, constipation, diarrhea, acute abdomen, or an ugly one, you knew that was coming, appendicitis, cholecystitis, cholelithiasis, or an ischemic bowel, all of those you or I would experience as incredibly painful. Not the person with spinal cord injury. No. They just get autonomic dysreflexia, stroke out and die. Suboptimal. Let me read your lips. Suboptimal, yes. Or a hernia, trauma, cancer, again, can cause pain in a person who is sensate. But for a person with spinal cord injury, it just provokes, this is a noxious stimuli below the level of the injury and provokes autonomic dysreflexia. Skin lesions, so pressure injuries, notorious for causing this, but lacerations, burns. I can't tell you the number of veterans that I've managed over the years. Back in the day, we didn't have cell phones, so they weren't right there in their pocket. We had landlines phones, and they would have to go across the room, and so they'd be cooking, and they would just put the skillet on their lap, and they would wheel over to answer the phone, and then not realize suddenly they've got second and third degree burns on their legs. And it's crazy, but more than 50% of veterans that I've managed over the years have these scars on their legs. It's crazy. Other causes, ingrown toenails, also notorious for. And why does this happen? Folks, especially those of us a little bit older, which includes you guys, are used to getting a certain shoe size, right? You've classic, for the last several years, you get a 10. Size 10 works. Not after a spinal cord injury, because you have relative edema in your lower extremities and your feet are somewhat swollen. And so you still push your feet into those tiny shoes now, causing ingrown toenails. Autonomic dysreflexia, stroke out and die. What? I told you to get the number 11s, right? So you have to help folks understand this. And then skin cancers. What? Skin cancer below the level of the injury can actually cause autonomic dysreflexia. Musculoskeletal causes, fractures. I've seen folks come into my clinic not knowing they've had a spiral fracture of their femur or tib-fib. Their foot is turned around backwards on their wheelchair, and they didn't know this because they don't feel it. Although, you know, I got a headache, Dr. Gator, and I'm sweating. And so, you know, we check, oh, that doesn't look normal. It doesn't take a great detective, but you need to know that these things can cause autonomic dysreflexia. Sprains, strains, and automobile, no, wait, that was a different movie. Strains and sprains usually are painful, right? But not if you have a spinal cord injury. Instead, it's just a noxious stimuli below the level of the injury and can cause autonomic dysreflexia, hypertensive crisis, stroke out and die. Suboptimal, bring it, okay. Heterotopic ossification can be painful for you or I, not with somebody with spinal cord injury, they just get autonomic dysreflexia. And then infections, tumors. It's not a tumor. It could be a tumor causing autonomic dysreflexia. Genital causes. So for men, yes, erections, priapism could be painful. Not if you have a spinal cord injury, you just get autonomic dysreflexia, stroke out and die. Testicular torsion. So this is something that oftentimes happens. They shift the patient in bed, not realizing that the testicles are now twisted and lying underneath great weight. You or I would experience that and say, ouch, but they don't. They just get autonomic dysreflexia of unknown origin. So as you're in the midst of assessing the patient, reach down and try to reposition things in order, oh, look at that, his blood pressure just dropped. How crazy is that? So that's not a pearl, that's a jewel. No, that's a pearl. Just keep that in mind. Women also can have orgasm, and in the midst of that, get autonomic dysreflexia. The other thing, and I've not experienced this, but I've known women who have, they tell me that labor and delivery is painful. It's also considered a noxious stimuli below the level of the injury and can cause autonomic dysreflexia. And so we need to work closely with our obstetricians, gynecologists, and anesthesiologists for women who go, they have a spinal cord injury, they shouldn't feel any of this. No, they're going to have spinal cord injury with autonomic dysreflexia, stroke out and die giving birth, which would be especially suboptimal. But wait, it's not over once they've delivered the baby. They go to nurse, and if they have a C7 spinal cord injury, those nipples are at T4, which is below the level of the injury. And so when the little tyke latches on, again, women could tell you this is painful, but not if they have a spinal cord injury. This is a noxious stimuli below the level of the injury and can cause autonomic dysreflexia, stroke out and die. And there's case reports in the literature of this happening the first time a woman nurses her baby. Needed to get that off my chest. So cardiovascular causes of autonomic dysreflexia. Myocardial infarction, that's painful to most people. Angina, right? But not if you have a spinal cord injury. Pericarditis, pulmonary embolus, DVTs, vascular claudication. All of these typically associated with pain, chest pain, but not if your spinal cord injury is above the level of these afferent influences. Now, this is a noxious stimuli below the level of the injury and can in fact cause autonomic dysreflexia. So what you don't want to have in the middle of a myocardial infarction is an increased afterload caused because of the pain. And so these folks will go downhill very, very rapidly, which is why I always like to have a baseline 12 lead EKG. And I'm going to ask you to get that immediately when somebody starts to experience autonomic dysreflexia, to make sure that it's not a heart attack causing the autonomic dysreflexia, or they're going to spiral down in a matter of minutes and die. So acute management of autonomic dysreflexia: elevate the patient's head, not your own, but keep your own head above. Loosen tight clothing, leg bags, etc. Check in order the bladder, the bowel, and then other sources of autonomic dysreflexia, and consider pharmacological intervention. What does that look like? Acutely, nitropastes typically is what we use. Now, for years, Dr. Kirschblum out of Kessler has told people, when you use nitropaste in spinal cord injury, put it on their forehead. And people thought that that was some magical way to get your blood pressure down quickly. No, no, no. It's a magical way of not forgetting that you put nitropaste on. And so, you know, typically you can still put it on the chest, but you have to realize once you have got the person's blood pressure under control, you need to wipe off the nitropaste, or they're going to go into hypotensive crisis. And so it's just a reminder. Many people still put it up here. I still advocate for the chest, but be aware that you're going to have to remove the nitropaste once you've found the source, or their blood pressure is going to continue to plummet. Other things that have been used and still are in some cases, the Procardia SL is provided, nifedipine SL. But what about those circumstances in which it's not just, you know, the bladder was distended, or let's say that you found one of these folks with the spiral fracture, or you have a grade 4 pressure injury. You, as good as you are not going to heal that overnight. And I know some of you are amazing, but I'm just saying. And so you're going to need something else on board to keep their blood pressure from causing them to stroke out until whatever this is has healed. Now, I mentioned dibenzoline earlier. It used to be great, easily available and whatnot. Now it's pretty rare to find it, and it costs buku, what is that? Buku, that's a lot of dollars, okay? So instead, typically I will jump to terazosin, which has worked pretty well for me in the past. And typically I will go with a 3 milligram dose, just kind of in between these as a starting point. You can titrate this up to 20 milligrams a day. It's relatively inexpensive. Until such time as you've taken care of the source, the noxious stimuli below the level of the injury. So you should have Quickset orders available to you now in Cerner. And I know you've got these on all of our spinal cord injury patients, right? So if their blood pressure exceeds 120 over 80 or is 20 millimeters of mercury above baseline, this is what the orders tell the nurse to do. Check the Foley for blockage or kinking, check the bowel for impaction, loosen restrictive clothing on the patient, mind you. The nitroglycerin 2% ointment should be administered 1 inch if the blood pressure is greater than 140 over 90, 2 inches if it's greater than 170 over 90. And then when the blood pressure comes back down, and it may, wipe off the nitropaste, alrighty? Continue to look for the source. What is the noxious stimuli? And then if unresolved, the nurses should contact the physician and or APP. So, hypertensive crisis in spinal cord injury is amplified for several reasons. The cardiac reserve is markedly diminished after spinal cord injury. With a decreased afterload and a decreased preload, you have an adaptive myocardial atrophy. The heart simply isn't as strong as it was when the person was neurologically intact, okay? So you don't have as much time. You also got vascular smooth muscle that is atrophied, and this could lead to rupture because simply the smooth muscle of the vascular tree in the brain isn't as responsive as it once had been. But even in neurologically intact adults, increased afterload morbidity associated with stroke 25% of the time. Causes pulmonary edema 22% of the time. This is in neurological intact individuals. Hypertensive encephalopathy 16% of the time. Heart failure or acute myocardial infarction 12% of the time. So this warrants aggressive management of the blood pressure to get it back down to baseline. If necessary, use nitroprusside, phentolamine, and hydralazine. Avoid beta blockers because you've got that whole reflex bradycardia that you're dealing with in autonomic dysreflexia. You're going to monitor the vital signs frequently. How frequently? Every 10 minutes or so. And then if you find papilledema, jugular venous distension, crackles, and significant lower extremity edema, neurological changes, then you're too late. And you've already going to have some significant consequences of this hypertensive crisis. If the person is symptomatic, get that EKG, consider cardiac enzymes, provide oxygen, and monitor their pulse oximetry, and consider a chest x-ray. Consider an ICU transfer, not a transfer to the medicine floor, but an ICU transfer to manage blood pressure, prevent target organ dysfunction, TOD. Otherwise, you'll end up like this gentleman did. He was found unresponsive and without a pulse when the nurse went back in to check him on your orders. They called a code, and he was found to be in pulseless electrical activity. 30 minutes of resuscitation and intubation later, he was found to have an anoxic encephalopathy. The family and his orders indicated that he didn't want to continue in this way, and we discontinued the ventilator. At autopsy, he was found to have acute and chronic interstitial nephritis associated with those stones, bilateral pulmonary congestion related to the high afterload that he was trying to overcome, bilateral pleural effusions, but minimal coronary artery disease. So this unfortunately does happen, and there are many more case reports than I would like to admit with regards to mortality associated with autonomic dysreflexia. And yet, some of our folks who are actually in pretty good health will invoke autonomic dysreflexia on purpose. And we call this boosting. Particularly athletes who are trying to offset the circulatory hypokinesis associated with upper extremity exertion, lower extremity pooling. And they will bump their blood pressures up significantly 2 times normal or more during the midst of their athletic endeavors. So always be aware if you're going to be monitoring these events with spinal cord injury patients, flushing and sweating. Oh, wait a minute. What are the side effects of exercise? Flushing and sweating. So you need to have a high index of suspicion when you're monitoring these folks. They will sit on a tack on purpose. They will pull their leg bag too tight around their legs to cause autonomic dysreflexia so that they will offset the circulatory hypokinesis. They will crank their knees into sprained positions to cause autonomic dysreflexia, to maintain their blood pressure during competition. So be aware of all of that. Also be aware that thermoregulatory responses after spinal cord injury are blunted, okay? They are like lizards, is one of my favorite docs from back in the day at Richmond. Dr. Ted Castillo would talk about thermodysregulation after spinal cord injury. They become poikilothermic. They will take on the ambient temperature around them. And so in Miami, you may see somebody who, out on a hot summer's day, they lose consciousness. And you think immediately, what? Hyperthermia, you know? But if they were sitting in the shade with a light breeze going by, they will take on the ambient temperature around them and become hypothermic. What? Hypothermic. Their body temperature will drop down to 94 degrees. And so be aware of these dysregulatory responses as we talk about temperature regulation. And then finally, all of you should have the little booklet along with your neurological standards for neurological classification of spinal cord injury. You should have the autonomic standards where we talk about responses to, so bradycardia, tachycardias, these uncontrolled sweating episodes, temperature dysregulation, etc. We do galvanic stim responses in folks with spinal cord injury if we want to know the level of their autonomic dysfunction, for example. And so if you're going to report this, you report it as normal, reduced, or altered, or complete loss of control as you go through this. So we have the equipment to do a fair amount of research with autonomic dysfunction after spinal cord injury, looking at cardiovascular responses, but as well looking at pulmonary responses, et cetera, as we look through these things. So I wanted to open this up for questions. There's a lot of information conveyed very, very quickly. The main thing to remember is that anything that would cause you pain below the level of a spinal cord injury is a potential culprit for invoking autonomic dysreflexia in our folks with injuries T6 and above, complete or incomplete. So, thoughts, questions, concerns, gripes, groans, psychic moans? No, that's another lecture.
I have a question, Dr. Gator.
Yes.
This is just CNM from PT. So are you guys discharging patients who have either a known history or high risk for autonomic dysreflexia with those prophylactic or emergent meds that you mentioned?
We should be. In fact, I'll find out today because I'm seeing one of them in my clinic. But yes, I would like to send them home with NitroPaste with the understanding of this is how to use it. The problem is, and you know this as well, the person who is discharged and has not yet had an episode of autonomic dysreflexia, doesn't know what it is, doesn't know it's a problem, doesn't know except they're feeling bad and they show up in the ER where their pressure is, 110/80 and the ER physicians haven't heard of autonomic dysreflexia, fill their bladder, cause worsening because they think that they're potentially septic. Anyway, these are things that, yes, we need to be checking on. And it's why I like to see folks relatively soon after discharge. Thank you. Okay. Excellent point.
So then, follow-up question. So
yes.
We've had individuals who, of course, want to still remain sexually active. They'd like to orgasm, ejaculate, etc. If we know that there's a risk for autonomic dysreflexia with these activities, do we advise the patient to monitor their symptoms? Should they take a prophylactic medication, given that they know that they're going to have that episode? Like, what is your advice in those instances?
Yeah, this is ongoing discussion, and when I do my presentation on sexuality and fertility, I'll bring this up again. Because typically, for erectile dysfunction, we prescribe that little blue pill, which causes vasodilation and erection, et cetera, et cetera. And it's contraindicated to use NitroPaste, for example, if you've given somebody Viagra, sildenafil, or one of those other medications. So we really have to do a lot of education and counseling to them as well as the pharmacists. So the pharmacist who sees, wait a minute, you're giving this patient NitroPaste, but we have to explain to them we're not giving them NitroPaste for angina, we're giving it to them for autonomic dysreflexia. And then we have to help the patients and the pharmacists understand that when you take that little blue pill, that could cause your blood pressure to drop. Now, you may get autonomic dysreflexia in response to that. It may still be appropriate if you have priapism to put on the NitroPaste. But now we've got this really difficult situation to manage. And so it requires a lot of education before I send them along this road.
Yeah, because I'll have some individuals who will use like electric stimulation, or they'll use vacuum pumping and all this different stuff. So it's a localized vasodilator, I suppose, in that sense that it's increasing the blood flow to the area. But I haven't had a lot of people using like Viagra who have had dysreflexia.
So oftentimes they will do both, and the electric stim can cause autonomic dysreflexia. So we also, and if they're going to use vacuum pumps, if they develop priapism, we also send them home with medications that they can take to help, manage that undue swelling, for example. So these are great discussions, and they will come up again, so to speak, when we do the sexuality for fertility discussions.
Perfect. Thank you.
Right. Any additional questions, thoughts?
Just a general question. I'm sure it'll probably be addressed later on, but I assume, do you see AD also in women breastfeeding? Is that something that's commonly seen also?
Yes, that's what I talked about earlier. So a T4, an injury above T4 doesn't spare the nipples. And so a noxious stimuli at the nipples can cause autonomic dysreflexia, and there's case reports of women stroking out as they nurse their child. So it needs to be discussed with the lactation nurses and the OB team and the moms to be before they have that first episode. And they need to recognize that it may not be safe for you to nurse. These are ongoing discussions that physiatry needs to continue to be available for folks. Excellent point. Thanks. That's when I said I needed to get that off my chest, that maybe you missed that. All righty. Thanks all. Everybody have a good day. We'll see you later.